Hello everyone, Assalamu alaikum. Welcome to my Taseer Gynaecological new department. I'm Dr. Komal Parvez and belong to medical profession, and my goal is to share my knowledge with all of you. Whether you are a medical student or someone wanting to learn about women health, so don't forget to subscribe to the channel and press the bell icon to get notified every time I upload a new video. Let's begin today's topic. We are going to study about the menorrhagia. Audience, can anybody define menorrhagia for me? Okay, I'll wait for your answer. Let's come to the lecture again. Menorrhagia is also known as heavy menstrual bleeding. This is common gynecological complaint, but its causes range from minor hormonal imbalancement to serious pathologies like endometrial cancer. Proper evaluation and individualized management are essential. Basically, menorrhagia is menstrual blood loss exceeding 80 milliliter per cycle or bleeding that lasts than 7 days, occurring regularly. Most women cannot measure blood loss, so clinical assessment focuses on subjective complaints. Soaking through pads tampons in less than 2 hours, changing protection overnight, passing large clots, limiting daily activities due to having flow. Guys, do you know that menorrhagia can lead to anemia, fatigue, and poor quality of life? Audience, do you have any idea why menorrhagia happens? No. Okay, let's talk about the causes of menorrhagia. Causes including menorrhagia causes are classified in 2 types. Number 1 is structural causes, number 2 is non-structural causes. Let's talk about the structural causes. Polyps, endometrial or cervical, often cause intermenstrual bleeding. Adenomyosis, endometrial tissue inside the myometrium, painful heavy bleeding. Leiomyomas, fibroids, especially submucosal types, increase bleeding surface. Malignancy, hyperplasia, endometrial carcinoma or precancerous condition. Now let's talk about the non-structural cause. Coagulopathy, for example, non-violent diseases up to 20% in adolescents. Ovulatory dysfunction seen in polycystic ovarian syndrome, adolescence, premenopause, hypothyroidism. And endometrial dysfunction when no other cause found, abnormal local hemostasis. Estrogenic intrauterine devices, anticoagulants, for example. Audience, let's come to the clinical tip. Always consider age-specific causes. Adolescents, coagulopathy and ovulation, reproductive age including fibroids, polyps, polycystic ovarian syndrome, premenopause including postmenopause, hyperplasia, malignancy. Audience, now we are going to discuss about the pathophysiology in detail. Let's explore what actually causes the excessive bleeding and ovulation, no corpus luteum, no progesterone, unopposed estrogen, endometrial proliferation. Fragile blood vessels, irregular shedding, heavy flow, fibroid and adenomyosis, increased vascularity and surface area of endometrium, heavier bleeding, platelet dysfunction or coagulation defect, intrauterine diseases, induced bleeding, particularly proper intrauterine devices can trigger prostaglandin release. Endometrial hyperplasia, cancer. Now we reach the diagnosis of menorrhagia. A structured approach is crucial. History, including menstrual history, duration, volume, clots. Intermenstrual are postcoital bleeding, obstetrics, contraceptive, surgical history, medication use, anticoagulant, hormonal, family history, bleeding disorder, systematic sign, thyroid, liver diseases and weight changes also. Audience, as we know, we must go for the physical examination. So let's talk about the physical examination. We must see the color of the patient, either it is a paler or not. Have a look for BMI, pelvic examination, masses, tenderness, cervical lesion, and bimanual exams as well. Uterine size, shape. We also go for the investigation. We do CBCs to check anemia, platelet count, TSH, prolactin, rule out endocrine disorder, pelvic ultrasound to rule out fibroid, adenomyosis, endometrial thickness, endometrial sampling, biopsy. Now let's explain the risk factor of menorrhagia. Obesity, diabetes, polycystic ovarian syndrome, persistent bleeding despite treatment, hysteroscopy for direct visualization, consider coagulation profile if bleeding since menorrhagia or if family history. That's all. Now, as you know guys, management of any disorder is very important. So talk about the management. Goals of treatment: control acute bleeding, prevent recurrence, address underlying cause, improve the quality of life, preserve fertility if desired, acute heavy bleeding emergency, high dose IV estrogen, conjugated estrogen 25 mg IV, chronic medical management, hormonal management, combine oral contraceptive, regulate cycle, reduce flow, progestins. GnRH analogs for fibroids, short-term use only, surgical management, polypectomy, myomectomy, fertility preserving. Endometrial ablation for women not wanting future fertility. Hysterectomy, definitive for refractory or high-risk cases. Guys, this is very important point, note it. Always offer iron supplementation and treatment underlying anemia. Now I'll share with you 3 cases guys. Special situation and case. Case number 1. 16-year-old girl with heavy periods since menorrhagia, likely causes coagulopathy or anovulatory cycle, evaluation, CBC, PT, APTT, VWD screening. Case 2. 42-year-old women with heavy bleeding, with clots, uterus enlarged, and likely causes submucosal fibroid, and investigation TVS MRI if needed. Case 3. 48-year-old female with obesity, diabetes, irregular bleeding, likely cause endometrial hyperplasia or malignancy. Investigation TVS plus endometrial biopsy. Management based on biopsy, medical or surgical. Audience, as you know, counseling, follow-up and conclusion is very important. Counseling points: reassure that heavy bleeding is treatable, discuss treatment and goals and symptoms, control, fertility and convenience. Emphasize compliance with medication. Monitor hemoglobin and treatment response. Educate on red flags, symptoms, intermenstrual or post-menopausal bleeding. Conclusion: menorrhagia is common, but evaluation must be systematic. Management depends on the cause, patient age, fertility wishes, and severity. With proper care, most patients achieve excellent symptoms control and improved quality of life. Thank you so much for watching. I truly hope this video helped you understand women's health little better today. If you found this valuable, don't forget to like, share, subscribe to the channel, and comments below your question. Also click the bell icon so you don't miss the next video in our gynecology series. So see you again in the next video with informative topic. Until next time, stay healthy, stay informed, stay empowered. Bye bye.